Hello, my name is Rachel Fair, and I'm the Heart Disease and Stroke Prevention Coordinator for the South Dakota Department of Health. I'd like to welcome you to the second of a four-part webinar series on quality improvement. This webinar is being recorded and will be posted online to the DOHQI website, which is listed in the download box on the lower right side of your screen. All registered participants will also receive a link to the recording shortly after the live presentation. So throughout today's discussion, please feel free to type any questions or comments you have in the chat box at the bottom of the screen. There will also be time to discuss after our speakers finish their presentation. Please note the phone lines will be muted throughout the presentation to minimize background noise, but you can unmute yourself by pressing *6 if you have a question. Finally, you can download a PDF of today's presentation in the handouts box located on the bottom left side of your screen. Before we dive into today's discussion, I'd like to let you know a little bit more about why this webinar series was developed. In January of 2016, about 24 healthcare professionals began developing a strategic plan for a statewide cardiovascular health. It was finalized and implemented in 2017, and the current version of this plan is what you see here. It can be found on the South Dakota Department of Health's website listed on the bottom of your screen. During the process of developing the strategic plan, 4 different goal areas were identified as denoted by the different colored columns. Each of the 4 goal areas has a work group focusing on the area's designated strategies. The first thing the Prevention and Management Group decided to concentrate on was encouraging the implementation of quality improvement processes in health systems. Before the group could figure out how to do this, they had to first establish a baseline. So a QI assessment was completed via email survey. Results indicated there's a wide range of knowledge, staffing, and implementation of QI throughout the state. It was also evident that there is a disproportionate amount of resources available to facilities depending on their location, size, affiliation with the health system, etc. Based on the survey results, the work group decided to compile a list of resources already available related to quality improvement and house them in an easily accessible place on the Department of Health website. After completing that, the work group decided to expand this resource guide into a toolkit which will include further information related to the QI process as well as case studies and additional helpful materials. This webinar series has been developed to complement the information included in the resource guide and the toolkit being developed, and to serve as a platform for professionals across the state to promote discussion around QI needs, encourage partnerships between organizations, and provide an opportunity for successful QI initiatives to be showcased so as to hopefully spark similar projects across the state. During today's webinar, we'll hear an overview of quality improvement, followed by information on how that relates to population health. So to get us started, I'm going to hand things over to Holly Arends, Program Manager at the Great Plains Quality Innovation Network.
Well, thank you so much, Rachel, and welcome everyone. And as Rachel said, I'm Holly Arends, and I'm with the Great Plains Quality Innovation Network. You also may know us as the South Dakota Foundation for Medical Care. The South Dakota Foundation for Medicare is your QIO for the state of South Dakota, but as a network, we're 4 states, which would be North Dakota, South Dakota, Kansas, and Nebraska. And the GP Quinn is a CMS-contracted Quinn QIO, and we're tasked to provide technical assistance to Medicare providers on the high-priority tasks that CMS has identified. And some of those things are, as we are meeting today, in regards to cardiovascular health, also diabetes, participation in the quality payment program, the IQR program, the OQR program, sepsis, colorectal cancer, immunizations. There's a wide range of things that we're working on, and this is one of the tasks that we're helping with, and we're glad that you're here today. So let's get started, and we are going to be talking about the basics of QI. And I know a lot of you have probably heard lots of things like QA, QI, PI. There's so many different things out there, and sometimes it gets really confusing. So let's just define a couple of the things, and first is quality assurance. So this is really the method that you use to audit, that making sure that you are adhering to predefined standards. So that may be if you're accredited by JCAHO, they have standards. If you are going off the conditions of participation, or if it is the state rules and administrative rules and laws, that is done by utilization management, usually infection control, risk management, quality department, credentialing, peer review. So that's really what QA is just ensuring that you're meeting the standards that have been put in place and govern your facility. Now, quality improvement, this is that continuous process where you review, plan, and test improvements based on what you saw in quality assurance. So if you're trending something in quality assurance that you see, we're not really meeting the standard here, let's go take a look at it. And you're using that data to make some decisions. So quality assurance is the first step in quality improvement. It does require some standard methodologies that you use for quality improvement, and quality improvement always is focusing on systems and versus individuals. So it's a blameless culture and making sure that we're doing systems thinking. Now, performance improvement, this is that continuous study trying to exceed or meet the expectations of your patients, which really defines quality. So we have our first polling question out here, and I'd like to know, could you describe to me your quality staff structure at your organization? And you can select one of these, and then Chantrice will get us some of these results to see what kind of mix we have. Oh, I see. Good. We're getting some answers here. Excellent. Keep them coming. All right. I think we probably have. I'll send those results out. And Chantrice, if you can just put those up on the screen for us so we can see those results. So it looks like we've got a pretty good mix here, full-time staff dedicated to quality improvement. Got some full-time doing QA and QI and additional duties, and then there's those folks that have that stack of hats, and QI and QA is just one of those. So thank you very much. That's usually what I see out in the field as well, that the practices that we work with have different understanding and different knowledge base of quality improvement. But I want to tell you that, there may be some myths about quality, and it may seem like someone may hold all the knowledge within your organization, but really it's no smoke and mirrors. There's no magic here. It's really straightforward, and all of us do quality improvement in our daily lives, so it's not something that has to be scary for people, and it should be something that can be taken to the masses and they can do within their own duties on a day-to-day basis. The one requirement that you must have, though, when you are trying to do quality improvement, that leadership must mandate that change. So they create the vision, or they create what needs to be changed, or the goal that you're trying to get to. So that, it's not only step one, it is the ultimate step for success. We're going to go through each one of these things so you fully understand them, but the rest of the steps in the process, once you get leadership to articulate that vision or that mandate for change, is identifying the opportunity. Step 2 is choosing an approach. Step 3 is collecting data. 4 is analyze the data. 5 is implement the plan. 6 is evaluate the plan. And 7, improve the plan. And then once you have gone through those steps, it's really holding those gains and making sure that you sustain that improvement. So first one, step, identify that opportunity. Again, we said that mandate for change. And sometimes, it could be a single event that happens, or it could be a culmination of things that there finally is a lever of change or a mandate for change. And that could be an incident that may have happened, and you've done a root cause analysis on that incident, and it identifies areas for improvement. It could be any type of program or priority at both, any of the national, regional, or local level. It could be based on your strategic goals or your business goals for your organization. They may be budgetary in nature. And it also could be patient needs, your community needs, or the conditions that you are seeing may be changing. So let's say you have diabetic patients now that you're seeing increase in cardiovascular comorbidities. That may prompt that mandate for change. Now, again, you want to make sure that you understand what the vision is for this, because you need to be able to communicate that and articulate that to the others that are going to be in your team and also organization-wide. So to have that leadership support, it must be visible, and that really is in different ways. So they could create a charter for this type of work, and then they could assign a project sponsor, a champion. It may be a clinician, it may not be a clinician, depending on what type of project you're working on. They also visibly create a culture of quality, and that would be that the policies and procedures are all pointing to systems thinking, that there is a no blame type of culture, near misses are investigated, we celebrate the good catches, those types of things. So creating that culture. The infrastructure they set up, and also the resources that they dedicate. So when they say, okay, we're going to charter a QI project and we're going to assign staff's time. So let's say we have some floor nurses, and we're going to assign 2 hours per week that they can work on this project. That's the type of visible support that you have to see. And then they also will be discussing the progress and these projects at leadership level meetings. So if it is a business meeting at the clinic where the physicians all come together, and there should be a portion where they discuss what projects are being worked on. That's that visible portion. Their commitment really, again, I'll repeat, that it's really vital to your success in a quality improvement project. So this is an example. You have to have some type of elevator points, or, just a couple of reasons why you are doing this project. So for controlling high blood pressure, here's a couple of things. So this is a national reason. 610,000 people die of heart disease in the United States every year. That's 1 in 4 deaths, making it a leading cause of death by disease in the U.S. Okay, that's a pretty good reason. Another may be that your provider's performance on your controlling blood pressure measure has been below the benchmark, and you've set your goal, so there needs to be some changes to move that needle. Or maybe your providers that have instituted a new blood pressure protocol, and they want to incorporate maybe a self-measurement program, and you need to improve. That would be an improvement on this project as well. So there can be many different mandates for change, but you have to be able to have those in your memory so you can recite those to people to say, okay, here's why we're doing it. Because most people, when you are trying to change things, there's some fear, but once you give them a reason why this is happening and you can attach that to their value system, it becomes easier to accept change. Okay, so next thing is you need to develop a team. Always to have a team leader, a champion, a technical expert. So you do need to have some IT people there, or in terms of clinical experts. Also, a quality facilitator is really nice to have to help you understand that quality process if you do have some people who maybe aren't familiar with that. Ad hoc members, as needed, you may have pull people into a meeting. just ensure that you have roles and rules established for your meetings, and the more detailed you can be about what the vision is for the project, the goals, the timeline, and providing some education to make sure that everybody has the same knowledge base of QI is really important. And those things, we have resources for that, and you can get those on that Quality Improvement Resource Guide link. So, the main statement, what are we trying to accomplish? Make sure you, the first thing when you sit down in your meeting or when you have your first project charter is done is ensure that you have set the true north of what are we trying to accomplish. Clearly defined, measurable, using your mandate for change to help write this statement, and then also how will we know if there is an improvement. So we can't be ambiguous about this. We want to ensure that we can track this and make sure we've seen success. Step 2, choosing an approach. Now there are several approaches out there. For this particular project that we're working on with the Cardiovascular Collaborative, we've chosen the Plan, Do, Study, Act, which is PDSA in the acronym. But there are several. You may have heard of Plan, Do, Check, Act, PDCA. There are other types of analysis. You can use the failure modes effects analysis to see where failures would be within the process. So it really is about picking what fits your project and then also picking what fits your staff as well. You may have staff that are trained in Lean, so they may work out of the Kaizen, or so it's all about knowing what knowledge base you have within your organization. We're going to continue in this PDSA methodology for this webinar. Next is collecting data. Okay, so you may have many different places where data is being collected. Now this may be through your EHR. This may be in an analytics program. It may, God forbid, even be a manual paper log that's out on the clinic floor or out on the hospital floor that is tracking some information. So when you're in your first meeting and you're thinking about the measure and saying, okay, so where are we going to collect this data, you have to look at all formats, okay? And if you don't know, that's where you would want to bring an ad hoc person in and say, okay, from the nursing floor or, acute care or peds, wherever it is, that your population you're going to be discussing, where do you collect certain information, and make sure that you know that. Understanding what your data set is really important. So if you're looking at a workflow and you're saying, okay, when they admit a patient into the hospital or, admit them for the clinic visit, we take this information. So you know what data is collected at that time, what's required, what's not required, and all the way through the workflow process. So understanding your data set is important, and also on your measures that you're going to be using to show success of the project, understanding those data sets and what they're actually looking for in a measure. And we're going to go through a specification of a measure to kind of show you that data set. And then thirdly, for data collection, you have to know, what goals or benchmarks you're going to be comparing yourself to. So identifying who those sources are. So if you're using a standardized measure, possibly an NQF measure or a CMS measure, then you would identify what the benchmark is, and that also you could use the benchmark as your goal, or you can create your own goals off of that. Okay, so next you're going to look at the workflow. And again, this is where you'll bring in ad hoc members, or you'll go to them and say, you know what, let's just map it out, and we'll take sticky notes and we'll just map the whole thing out. And make sure you have the people that actually do that workflow in the room. because I can tell you, you'll have a supervisor or you'll have a director or a manager in the room that may understand the process to be one way, but the staff that actually do that will tell you about the workarounds that they've created based on what the managers told them that they should do, but they sometimes can't make that work. So ensure that you have the people that do that process in the room. And as I indicated, once you are mapping that workflow, identifying where those data points will be collected, and then making sure that you tie that to that measure specification. So and we'll look at the blood pressure measure. So if you are trying to find out systolic and diastolic of the blood pressure, finding out where do we take that blood pressure or that vital sign throughout the process, whether it's through a clinic visit or through a hospital visit, and where does it go within the EHR or charting in our chart? Where does it go then into our analytics? Is it going into the right measures there? So the workflow is one thing, but then you'll also have that subflow of data mapping. So this is a measure from CMS, and it's the pneumococcal vaccination. And I picked this one only because it had pretty easy denominator and numerator to understand. The blood pressure one was quite large, and I couldn't fit all the codes on here. So you look, the denominator is pretty simple. It's patients that are 65 years of age and older with a visit during the measurement period. Okay, so that's pretty easy when you're thinking about creating a report, or what data you're going to be collecting. You start thinking, okay, we're only going to be looking at patients 65 years and older, and if they have a visit during that measurement period. So whatever you've determined as your timeline in your charter or your aim statement, then you will be able to say, okay, from January 1st to July 1st of 2019, we're going to be looking at patients who are 65 years and older. So that's your denominator. Now, to get them into the numerator bucket, you'll see these are patients down at the bottom here, patients who have ever received a pneumococcal vaccination. So this is saying ever, so there has to be a way that you can look back, okay, and say if they've ever gotten one. So that may be a question within your triage. It may be that you have the system go back and look. So you have to go through these specifications to ensure that your team understands exactly what we're looking for, and having those IT people in the room too to help you understand, okay, so if you're going to say you want the system to go back and look, then there needs to be some programming written, some coding developed, something like that. So, you want to weigh all your options to collect the data correctly. Okay. Analyzing the data. You see, this is the part I like. I like looking at charts and graphs. And there's several charts and graphs that you can use to do this. So you can use bar graphs, line graphs, scatter graphs, histograms, whatever works for you. However you visualize or display the data should be understandable to your audience. So if you are going to be forwarding this to leadership, they may request it in a certain format. For your team, it may be that, we need to see a scatter to see where all the points are and move forward from there. So really looking at your audience and tailoring your visualization of data to them. So second polling question, and this is in regards to analyzing data. What systems do you use to generate data reports? And there's multiples here that you can answer. Lots of people using the EHR. Combinations, yep, good. Oh, good, there's no manual logs. I'm so happy to see that. Okay, getting a few more people. Give me just one more second. Okay, great. So we're looking, the majority are using an electronic health record, and a lot of people have a combination of systems. So yeah, absolutely, when we're talking about ensuring that we get those, identifying where are all the systems, where is all the data, those IT folks will really help you because they do have an understanding of where data is mapped, and they can help you understand where you need to pull information from. So great, thanks. All right. Let's see. Thanks, Shantrice. So looking at data analysis, I can tell you that when you start bringing data to providers and giving them feedback, the first question they have is about data integrity. So always plan a test sample to ensure that your data collection is correct. So this is during that plan phase of saying, okay, we're looking at, we've mapped the workflow, we've identified those data points. What's going to be our test or our little pilot to ensure data collection is correct? Once you do that, you'll have a justification to say, or, when they ask, how do we know this is working, you can explain how you have gone through that testing to ensure data integrity. This really does help to keep your project on track because that is one of those side rails that you kind of run into sometimes is ensuring data integrity. So thinking about it up front is important. Next, determining how your data will be displayed, and we did talk about that. If you don't have the ability to have an analytics program, Excel is a great way to just, if you can export your data to an Excel spreadsheet, they have really easy ways to create graphs and charts there, and that would be my recommendation. It's an easy way to do it without any type of analytics program. Then communicating that data, again, looking at your audience and ensuring that you're communicating it to all the people that need to know. I think sometimes we have a habit of communicating upward, but we don't communicate that lateral spread out to the people and staff that need to know. And, there is a real need to be transparent on our QI projects. And I would recommend that, if you have projects going on and you are seeing, improvements, impacts on your performance measures, to, throw that measure up on your website and say, you know what, and here is the QI project attached to it. And then your customers, your patients, can see how this process works, that you have a formal QI process, that you set goals, that you're working on things. And I think a lot of patients, families like to see that information. And as your data is becoming public on the CMS reporting websites, that it's sometimes good to have your own data out there so you can explain it in the way that you like. Also making observations. So when you're looking at data and there are either changes being made or we change, a workflow, make those observations in your data. So when you have a chart that you display over time, and let's say you see a drop or you see a spike, make a comment on that chart or, some type of narrative attached to that chart so you can show those observations. So when you look at that data also, you are also saying, okay, what are we seeing? Start making those conversations happen and looking at how you can make some improvements, because that's where we set that course for change. Is now you go through the brainstorming. Look at the workflow. Where do we need to identify changes? What if we change this? What will happen? What's the cause and effect? Step 5 is that implement. So this is where you've looked at the data, creating a work plan about what you're going to, change, and then doing those changes. So an example for blood pressure, in a workflow charting process, identified staff take the initial blood pressure, don't use a standardized technique. We need to do skills training. So you make that plan to do the skills training. You do it, set the date, get any information about what challenges or barriers you see, and next you evaluate, study it. Did it work? Did it have an impact? Do we need to retrain? Compare this to your prediction. And then step 7, continue to improve. So once you've looked at, a small change, tweak the plan. What's next? Okay, we've done the skills. Now we have to make sure that they, are documenting in the correct fields. So you just keep going through the process. It may be small incremental things that you do, or it may be one big change, but ensure that you continue to go through the process, because once you get to step 7, you really just go back to step 1 and start the process over. Any questions? I know I went through a lot, but I can tell you, if you use that Quality Improvement Resource Guide link, there's a lot more detail on all of these steps, and also there are resources and links to each one of these steps that will help you. So we're going to give you about 3-4 minutes to put any questions in the chat that you may have, or you can use *6 to unmute yourself and ask the question. Rachel, great question. Tips for smaller facilities with folks wearing 14 hats. It's always look outside your own organization for assistance. We are one of those organizations that can help you. Our services are free. I know DOH, we are partnering with them in the Million Hearts and the Self Blood Pressure Management Program. We also are working with the Compass PTN, and their services are free as well for smaller and rural organizations to help do this type of work. So in South Dakota, we really do have a great network of technical assistance here within the state. So it's really just reaching out to any of us. If you need help, if we're not able to provide that help, we can definitely find that person for you. So great question. That's the type of person, organization that we work with a lot. Those that are struggling to find, time in the day or assistance on certain things. So we can provide as much help as you need. Chantrice, thank you for the question. Leadership mandate for change as step 1 is clearly integral. If it's not already a priority for leadership, how can staff influence that? You know what? I have found that data and patient stories and staff stories always are the influencers and will attach to your leaders' value systems. So if you can, if you're not getting the support that you need, you may need to look at a specific patient story, or if it is a work safety type of thing where changes need to be made, specific stories, if those people can come with you to a leadership meeting, tell the story, and then have some data behind that, really does help to influence those people to create a mandate for change. Great question. All right, I'll take, okay, Sarah, great. Do you have any suggestions about how to recruit people to your team? You know what? Sometimes people see you coming and they don't want to be on a team. But really, this is where leadership steps in and says, part of the problem is because people have so many things that they have to do. It is difficult to get people on a team. But if you can offer that their time will be carved out for this particular work, that is a real incentive that they can dedicate some real focus and time to it. So great question. All right, I think we're going to move on to Patti Brooks. And I believe Rachel will give an introduction. So thanks so much, everyone, and I will stay on if you have any further questions.
Yeah, thank you so much. I work with Holly on several projects, and she's just a wealth of knowledge when it comes to this stuff. So I appreciate your presentation and great questions and answers for that. So now that we've got a good idea about the basics, let's dive in a little bit deeper. Population health is one of those things that we're hearing a lot about. So we're going to discuss how that relates to quality improvement. And for that, I will turn things over to Patti Brooks, the Director of Quality and Accreditation at Avera Health Plans.
Thank you. Can you hear me okay?
Yes, we can.
Okay, thanks. Great. Well, thanks for being here today. This is one of my favorite topics right now, so happy to present about this. Some of the things that I wanted to cover today was just to define population health and population health management, discuss some goals of population health, components of pop health, and define some various types of measures that we can use in pop health, and then discuss how the overall quality can be improved within a population health program. So the first thing I wanted to do was, what is population health? Population health is defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So it's an approach to health that tries to improve the health of an entire human population. The other thing that I think is a key component of population health, at least as we do it here, starting with our work at Avera, is looking at the patient holistically rather than individually kind of focusing on some particular diseases. And you'll see why when I show a framework here. So population health management can be described as the process of using big data analytics, but it doesn't always have to be real big data analytics. I want to emphasize that. To define patient cohorts, and you stratify those members by their risk of experiencing certain events, such as their risk of being readmitted or coming into the emergency room. So there's different things that you can stratify them by, and then deliver care targeted to their needs of the members, and then report on the individual and group outcomes to ensure quality and accountability. A data-driven approach to proactive preventive population health management is likely to produce more positive long-term outcomes for patients. So if you have the data, that's great, but if we have time, I wanted to just talk about some ways that we can use the data even if we don't have a lot of it, if we just have a small amount to start with. So population health is really a journey of change. It's a different way of thinking. We're constantly being challenged to not only take care of patients within the hospital, but we're also being challenged to prevent patients from needing to come to the hospital in the first place. So it's kind of counterintuitive, but will be financially incentivized as our reimbursement models change, because that's really what's happening, and that's what's driving a lot of the population health programs, is that whole change in reimbursement. There's growing evidence to suggest that pop health management can curb the impact of chronic disease, lower improper utilization of services, and improve patient quality of life. And the data analysis is necessary for providers to meet quality benchmarks as part of a value-based reimbursement. So these top health programs are often, if you have like an accountable care organization or you have value-based measures, often these quality measures are included in that, and if you're not meeting the quality measures, then your reimbursement is going to suffer. So I just wanted to talk about some goals and some strategies for pop health. So the first one is financial. A goal, decreasing costs by focusing on appropriate utilization, place of service, and prevention and wellness. So some of the strategies might be to focus on appropriate utilization, such as the number of admissions, the number of ED visits, and the number of readmissions. Focus also on appropriate facility for services, Does the person need to be in the emergency room, or do you have an urgent care available? Could they have gone to the doctor's office? Were they truly, should they truly have been an inpatient in the hospital? So really focusing on appropriate facility for their services. We're not saying they don't need any services, just focusing on the appropriate one. And then really focusing on prevention and wellness, such as screenings, the colorectal cancer screening, the breast cancer screening, cervical cancer screening, et cetera. And I never realized before working in a health plan how much that's what a lot of our quality metrics are about as a health plan, insurance plan, is making sure that people are getting in to do those preventive visits. On the clinical side, assess the health of the community to determine where the greatest needs are. So this is taking a look at your patients, focused efforts, and set clinical goals specific to the more prevalent areas. So such as diabetes and hypertension. Those seem like they always come out towards the top. Develop intervention programs to improve clinical measures, and then focus on both process metrics and outcome metrics. So an example of a process metric might be the cancer screening, the blood pressure readings, or the outcomes is the percent of diabetics who maintain their HbA1c. So there are both process and outcome measures to focus on. And then patient engagement is the third area. Building strong relationships with the patient. Find ways to engage with patients, because health and wellness depends on patients making healthy choices when they're not in the hospital or healthcare facility. Remember, this is about keeping people well. So health and wellness is a part of it, and you really have to meet people where they're at. If they're not ready to lose the weight, then they're not going to do it. So you really have to build relationships with the patient. Provide patients with resources, information, and opportunities to do a better job of managing their own health between office visits. And this is often done through a care coordination program that includes nursing care, medication management, working on social determinants of health, and health and wellness coaching. So here's an example of a population health framework. You'll see a few of them out here, but really they kind of are very, very similar. And the first part of it is identifying your population, the population identification, and then assessing where they're at, and then doing some risk stratification. And what I mean by risk stratification is determining how much risk they are. We'll go through another slide and you'll see that in a minute. But how much risk they are as far as their health. Are they somebody that is just perfect weight and they work out all the time, or do we have somebody that's on the road to a train wreck? So really it's understanding where they're at in the care continuum. And then you put the right resources in the right spot. So if it's a lower risk person, then typically you're going to be focusing on health prevention and wellness, doing that risk assessment. If they're more in the moderate range, then you're going to be focusing on, like maybe they're a pre-diabetic, you're going to focus on not making sure that they don't get worse. And then you also have, in the insurance world, we have people that are almost like catastrophic, so we're really working with them on some of their needs, and then also disease management. So you don't necessarily do it all alone. Within Avera now, we've just developed an enterprise care coordination, because we do some of it in the insurance area, and we were also doing some of it in the clinics. So we're kind of combining efforts to make sure we're not overlapping, but then making sure to pull in the right people in the communities, whether you have, if you don't have them in your hospital or clinic, a diabetic educator, maybe it's somebody within your community that does that kind of thing. So, or community health nursing or whatever. So really working with all the resources that you can. And then looking at metrics in the different areas. Can't read my slide here. It's the psychosocial, well, for me to read, I'm sorry. The basically it's the psychosocial, and then it's the, I can't read it here, but it's more like the wellness, behavioral changes, and then the clinical care, and then satisfaction scores, and then your financial outcomes. So looking at all of those is a good way to do it if you can. But again, if you're starting out small, first figure out probably where your utilization is and where some of those, a couple of diseases that seem to be more prominent. So the basic components I have listed down here are 4. Population identification, risk stratification, care coordination and management, and then operational measures and program outcomes. So the first one, identifying your population. This can be done by gathering key demographic and clinical data about the patients that are attributed to the provider. You probably hear about physician attribution, and that is kind of like the patient, who is considered to be their doctor, based on, it could be based on the number of visits that they've seen a different doctor, and if they haven't been in the clinic, which that happens, it could be attributed to somebody in the emergency room. So, but who have they been seeing if they've been seeing a doctor? And this can also be decided on the geography of the service area. Maybe you have people within certain geographies that a certain physician is responsible for. It could be your health insurance provider who's helping with that. It could be based on existing diagnoses. So there's different ways of identifying your population. The second step is stratifying, risk stratification. And if you look at this little pyramid here, you'll notice that this one has 3 categories of risk: the high risk, medium risk, and the low risk. So the high risk are your super utilizers of care. They have a lot of chronic things going on. They could be elderly people. They're in the hospital a lot. They're in the emergency room. They have psychosocial and socioeconomic barriers. And their costs make up 45 to 50% of the patients, but yet only about 5% of the people are in the high-risk category. So the impact, that's where you want to have your care coordination. Your care coordination could be a combination of nurses, social workers, pharmacists, whatever it is that you have available to help with it. And helping to address those psychosocial and non-clinical barriers, and we're going to talk about that a little bit further in a few slides down. Community resource navigation that I mentioned, intensive transition planning, and frequent one-on-one interactions with this group of people. The second one, the medium group, medium risk, is they're typically, I can't read, my slide is a little bit too small, I apologize. They're typically limited and stable chronic conditions. They're at risk for certain procedures, and their costs make up 30 to 40%. So some of the things that you can do to impact their care is to reduce some of that practice variation. Systematic care and evidence-based medicine, have a team-based approach, have scalable care teams, and practice at the top of your license. And then the smaller, or the low risk, is the largest bucket, actually, is 50%. These are your people that are healthy, they have minor health issues, and their costs make up 10 to 20%. In this group, you focus on coordination and prevention, and you move toward more virtual, mobile, anytime access if you can. Convenience for this group is critical. This area down here is one that we've been focusing on quite a bit as a health plan, because these are people that they have insurance, but they haven't come in for care, so we don't know if they're sick or not. So we are reaching out to them just to have a regular visit, just to make sure that they're doing okay. Third step, care coordination, and I talked about this a little bit in the last slide. These are for patients that are higher risk. They're going to need more frequent follow-up. Social and community support, enhanced care coordination services, medication adherence, advice, an invitation to enroll in special educational patient support programs. And the lower risk, again, it might be just automated screening reminders, calling out and reminding them that they need to probably get in and have just a regular office visit and establish a relationship with the doctor if they don't have one. And maybe there's some incentives to keep up healthy lifestyle habits. More and more should check out the insurance companies because a lot of them are paying for wellness benefits to belong to different rec centers. Okay, so I wanted to talk about a little bit about health factors affecting overall health, and this has to do with social determinants of health. So when we look at factors that are affecting health, this slide comes from the Robert Wood Johnson Foundation, which does a lot of work on social determinants of health and county health ratings. But basically what they're saying is that 20% of your care is really clinical care. The rest of it has to do with either your health behaviors, your social economic factors, and your physical environment. So it's really important for us to understand what else is going on with our patients and where can we help. So the social determinants of health are the environment in which people are born, live, learn, work, play, worship, and age that might affect a wide range of their health, their functioning, and their quality of life outcomes and risks. So the 5 general categories are economic stability, their education level, social and community context, health and healthcare, and neighborhood and built environment. So some examples of social determinants are access of resources to meet the daily needs, such as first of all, do they have a place to live? Do they have safe housing? Do they have a local food market? Do they have access to educational, economic, and job opportunities? Do they have access to healthcare services? What's the quality of their education and job training opportunities do they have? Do they have availability to community-based resources in support of community living and opportunities for recreational and leisure time activities? Do they have transportation options? Maybe they're not getting to their doctor's office because they don't have a way to get there. Do they have language barriers? Do they have literacy? Do they understand health literacy when you're telling them what might be wrong with them? Are you telling them in a way that they understand? Do they have access to mass media and emerging technologies? You know, we want everything. We want to give people reminders on their cell phone, the internet. Maybe not everybody has that, so we need to really take that into consideration. The reason I'm bringing these things up is because why do we need to look at the self-determinants? Because they do directly impact health. If you're given a prescription for a medication but you can't afford to take it, so your medication adherence is not there, it could be a matter of you can't afford to buy the medication. It's a matter of choosing between buying your groceries or keeping your heat bill on and buying the meds. So that's why it's really important to understand what else is going on in the patient's life or the member's life. And then step 4 is looking at some operational measures and program outcomes. So this can be done by looking at a lot of different measures. We have quality measures, clinical quality measures in the hospital. In the health plan world, we have HEDIS measures, which a lot of them are preventive, but not all of them. A lot of them are disease-related as well. CMS, AHRQ, there's a ton of them out there that probably you're all doing right now. You can look at outcomes on routine screenings, some adherence to industry treatment guidelines, or process or outcome metrics that are developed outside of the regulatory norms to determine if you're producing results. In that area, I'm thinking about some of the things like maybe if you have a health and wellness program going on, like looking at how many people are in the BMI category for overweight or obese, how many people have a elevated blood pressure, those types of things. So here are some examples of some metrics in a health screening program. For your health risk assessment, you could be looking at participants with various levels of nutrition, various levels of readiness to change, various BMI levels, how many people smoke, participants with a certain PHQ-9 score, looking at depression screening, and participations at various stress levels. And in the health screening part, could be looking at the people that are overweight, obese, have an elevated blood pressure or elevated blood glucose. Here's another example. These ones here are HEDIS metrics. So these are easy ones to do if you're looking at a diabetes population. Looking at the number of your patients that have an HbA1c testing actually performed, and if the hemoglobin A1c is less than 8, or if it's poor control, if it's greater than 9. Are they getting an eye exam every year? And is their blood pressure under control? So these, obviously the numbers might vary a little bit depending on what source you're using for your metrics. The other thing I wanted to mention, because this all fits in, is with the IHI Triple Aim. The Triple Aim is a framework developed by the Institute for Healthcare Improvement that describes an approach to optimizing health system performance. And the 3 dimensions are improving the patient experience, including quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. So why are quality measurement programs important in Pop Health programs? Pop Health is a large component of value-based programs, and quality measurement improvement is a part of value-based care. And I truly think that we're going to continue to hear more and more about population health programs in the next few years. And quality measurement helps seek improvement in access to care, medical or disease conditions, and social and economic underpinnings of society itself. So by developing robust population health programs, we're actually working towards a total transformation in healthcare and optimizing health performance as a part of the Triple Aim. So with that, does anyone have any questions?
And we are getting to the end of the hour, but I did want to just briefly ask, kind of similar to what we asked for Holly for our smaller facilities, is there anything that they can look at regarding population health that's going to be realistic for their smaller scale facilities?
Yeah, I think that's a great question, and it's definitely something that we need to keep in mind. Definitely, I think we can do things on a smaller scale. One of them would be looking at some of your financial costs. Like I would look at utilization, like emergency room costs, not just cost, but also the utilization and why people were there. Like for emergency room, if you have an urgent care, or could they have gone to the doctor during the day? Was an appropriate admission, those types of things. And then I think the other thing I would do is just take a look at your higher diagnoses that you're seeing, whether it's hypertension, diabetes. And if you have like a diabetes registry, if you can just create a registry of those people, and if you can include any social economic factors of knowing people that might have a little less advantage of things, I think those would be really good things to really kind of focus on.
Well, thank you, Patti. That was excellent.
Thank you.
So I just wanted to give you guys a heads up. There are going to be 2 more webinars focusing on quality improvement taking place over the next few months. So please plan on joining us for those as well. You can find the information under the webinar section on our quality improvement website. Also, recordings will be posted to the site after the presentations if you're not able to attend the live version. So next month, we'll hear from several partners in the field on the reality of implementing quality improvement in South Dakota, and especially considering our generally rural landscape. And then finally, after the completion of our quality improvement toolkit, we'll have a webinar that will walk you through a live demonstration of the resource and show you how to navigate the online materials. So we're in the process of finalizing the dates and times for those. So just be checking your email for more information on registration. And you can also check back to the website, and the links will be posted there as well. In closing, I'd like to thank you for joining us on this webinar and generally for your interest in better understanding quality improvement. Thank you for all the work you do to help keep our South Dakota residents healthy. If you'd like to find out more about the Quality Improvement Resource Guide, if you're interested in joining the Cardiovascular Collaborative, or if you'd like to discuss potential opportunities to partner, please contact me using the information listed here. Again, thank you for joining us today, and I hope to see you back for the rest of the webinar series.